Thank you everyone for watching the video. Welcome to First Aid AMC Clinical last session on free 2 weeks classes. So I hope that you guys are enjoying our sessions so far. And we have done a lot of free sessions for you, starting with the last month we started with psychiatry, MSc theory. We did psychiatry, MSc role play, followed by we did some cardiology classes. Then we also had a cardiology role play session. You also got 2 role play classes, which are random role play classes. And tonight is our last class on those free 2 week session, which is pediatrics vomiting cluster. As you can see that in 2 weeks, you actually learned a lot. So that's how our each 2 weeks are designed. It is designed in a way that everything that you need to prepare for this exam, you can get it just in a single course, and everything is available so that you can just read it, listen to the recordings, go through what we are showing you and asking you to do, and likely chance that you are going to pass this exam just like a lot of other candidates who has done this course and passed in their first attempt. Okay, so let's not talk too much initially. Let's start with our pediatrics vomiting cluster. And as part of our last session on those free sessions, we would just discuss a little bit about the course at the end, because the orientation class is coming up. Just within next few days, you guys will have your orientation class. So I always encourage everyone that if you want to join the course, and if you are ready to do so, please don't miss the orientation class, because we are going to discuss each and everything that you know to start your preparation fully. So please make sure that if you actually want to join before that class. Okay. All right. And also one of the other classes coming up, that's in, I think we have booked it in for 21st of May. Yeah. So 21st of May is your career guideline class. This is a part of the course also, like we take the class as part of the course, but also we make it free for everyone, because there are some information which I would like to share with everyone so that the life becomes much easier for you. Those informations, I had to wait for a long time to gather those information. Initially, I also had to find out from people. It was a difficult thing back then. Nowadays, you guys can learn from a lot of other people, and you can easily even get some free classes. When we used to do it, there was no free classes. So things changed a lot for IMGs, and we actually tried our best to ensure those things, that whatever support that we felt that's not there, we have always tried to make sure that everyone else is getting that. So that's why IMGs at the moment are getting a lot of jobs in Australia. Previously, if you look back to 5 years, the number of candidates who could get job offer, and if you compare it to this year and last year, there's a huge difference. And there is always someone who is helping on that, like, because if you don't know the enough information, then you can't actually decide what to do next and where to actually look at. So we have helped a lot of IMGs in that path, and we are happy to know that obviously people got help. They went to the right path, and they are now working in Australia, and their dream came true. So please make sure you don't miss that career guideline session. It will be really a good one. Okay. Let's start with our tonight class. So tonight we are going to do pediatrics vomiting cluster. Now, just like any other cluster, like in the cardiology, you came to know about cluster-wise approach that we follow. Just like any other cluster, vomiting cluster is also a very important part of your pediatrics preparation. It doesn't mean that your medicine preparation is over. Medicine and pediatrics, we do it like in between the other classes, because these two are vast. So medicine, in some time we will do cardiology, then we do respiratory. So in that way, time to time, every month we will have some medicine classes. Same with the pediatrics. But others like gynae, ops, psychiatry, those will be finished as a whole. Now, starting with the vomiting cluster, what are the differential diagnoses of vomiting in a child? We divide it into GIT causes and non-GIT causes. So GIT causes can be gastroesophageal reflux, pyloric stenosis, can be duodenal atresia, incarcerated hernia, intussusception, volvulus intestinal obstruction or Hirschsprung disease, acute gastroenteritis, or esophageal atresia or tracheoesophageal fistula. So all of these are very important differential diagnoses for vomiting in a child. The exam cases are reflux, pyloric stenosis, duodenal atresia, hernia, intussusception, Hirschsprung very rarely, gastro not that much, it comes as diarrhea, and also tracheoesophageal fistula. So you can see that how much important is this cluster. Okay, so all of this come in exam, and with just a single cluster-wise history and physical exam, you're going to learn all these cases today. Non-GIT causes are also important to rule out because vomiting in a child doesn't mean always has to be GIT causes, can be non-GIT as well. So we should rule out any infection like urinary tract infection, otitis media, septicemia or meningitis, pneumonia, and sometimes also in case we should also rule out testicular torsion. So UTI, otitis media, septicemia, pneumonia, and testicular torsion, these are your main differential diagnoses for non-GIT causes of vomiting. Now, let's start with the history. So first of all, when you get a pediatric patient, so the exam is designed in a way that there will never ever be a child in your role play station. So who will be there? The parents will be there. So either the father or mother will be there with you and you are going to talk to them. So there is no child in the exam, not in online, not in face-to-face. So in this situation, a parent will come to you because the child is vomiting for the last few days. Okay. So how you start this kind of cases? So let's say the mother name is Sarah. You can say, "Hi, Sarah, this is Dr. X. I'm one of the GP in this clinic. It's very nice to meet you. I understand." Now, let's say the child name is Jenny. Jenny has been vomiting for the last few days. I'm very sorry to hear that. But now that now that Jenny is here, we are going to take care of her and we'll try our best to find out why she's having vomiting like this. Now, because she's vomiting just recently for a few days, I would just need to make sure that she is vitally stable before I start asking any more questions. Same like cardiology cluster, if it is a case of online, then you will just say that, and then you will ask questions. Well, can you please tell me a little bit more about the vomiting? Because examiner doesn't answer your questions, you are not going to ask vital from examiner in online. But in case of face-to-face, you will go to the examiner and ask, "Dear examiner, I would like to know if the patient vital is stable for further history." Okay, so just like cardiology cluster, I'm not going into too much detail of that. Please make sure you remember how to do this two approach. Once you have done that, then you can ask, "Can you tell me a little bit more about this vomiting?" So the parent will give you some idea about the vomiting. But what you need to know is this. So you need to know that since when, how many episodes so far, what's the color of the vomiting? Is it greenish in color or is it whitish in color? Because if it is whitish, looks most likely like, if it is like a neonate or children who is breastfeeding, most likely it's just a breastfeed coming up. If it is bile stained or greenish, that's the time we are worried because it looks that there might be some intestinal obstruction or something is wrong in the intestine. Okay, so find out the color of the vomitus, any blood in it. What's the consistency? That means what is the content of the vomitus? So what's actually coming up? Undigested food coming up, digested food coming up. What's the content? How much it is? It is a small or large in amount? And is it very foul smelling? So this is called CCVO. In any kind of discharge, we always ask this question. Okay, so vomiting is kind of a discharge from the body, we say. So any kind of those, you will need to make sure that CCVO should be asked. So find out since when, how many episodes so far, what's the color of the vomitus, any blood in it, what's the content of the vomitus, is it a small or large in amount, is it very foul smelling? Then we ask few questions related to some of our differential diagnoses. So do you think the vomiting is forceful or projectile? Forceful projectile vomiting can be there in a lot of conditions, but especially it is a finding for pyloric stenosis. Any relationship to the food or feeding? If yes, how soon after feeding does she vomit? If immediately after feeding, child vomits, likely chance something in the upper GIT having some obstruction or problem. Like if a child is 24 hours old and whenever the mother tries to breastfeed the child vomits it out immediately. So likely cause is duodenal atresia or esophageal atresia. Okay, so more commonly esophageal atresia will vomit immediately after feeding. Sometimes even duodenal atresia, child can do that. So we need to find out that any relationship to food or feeding. If yes, how soon after feeding? And is he hungry immediately after feeding? If a child is hungry after feeding, it looks that child actually vomited everything out. Okay, so these are the few questions that we are going to ask as part of the history of presenting complaint, which is the vomiting. After we have done that, then we move on to the associated symptom. So along with the vomiting, have you noticed any distension of his tummy? Tummy distension is a sign of intestinal obstruction. Any lump or bump in the tummy or in the groin. You can't ask, have you noticed any mass in the tummy? Because that will be a medical jargon. So you can ask any lump or bump in the tummy or in the groin. So lump in the tummy is important for pyloric stenosis. So you might be able to feel a lump in the tummy. Intersusception can feel a lump. And lump in the groin is very important not to forget about because it could be an incarcerated hernia also. So these will be your first questions. Now, this associated symptom question is not must to ask here. You can ask all of this question as part of your differential diagnosis also. So if you can't remember the associated symptom question, then immediately after vomiting question, you can go to differential diagnosis. So starting with the GIT causes, first intestinal obstruction. So how I normally remember this vomiting question is first I ask vomiting, then I ask bowel and bladder, and then I ask all other differential diagnoses. So for bowel, how about his bowel habit? When was the last time he opened his bowel? Any history of diarrhea or constipation? So intestinal obstruction child will have history of constipation. They might say that last bowel opening was 3 days ago. Okay. So, and also you can see some tummy distension with vomiting. So that will be the finding for intestinal obstruction. Diarrhea will cover acute gastroenteritis. Then bladder. So how about his water works? We try not to use micturition in the exam. Urine is fine, but for children, they like pee and poo. Okay. So most of the time you can ask, how is his pee and poo? Or sometimes without urine, you can ask water works. They understand water works, they understand urine, they understand pee, they understand wee. So all of these are very commonly used in here. But don't say, how is your child micturition? That will be medical jargon. So how about his waterworks? Have you noticed any change in number of wet nappies? Any change in color or smell of the urine? And does he cry while passing urine? Now, while you are asking UTI questions, you are also assessing the hydration status of the child. If number of wet nappies reduced, it means child is not hydrated enough. So that's also very important to find out. Change in color or smell of the urine for UTI child, the parents will say that it's more smelly these days. And child might also having burning discomfort during passing urine, and they might cry during that time. So these two are for UTI. So after that, you move on to some of the other differential. So let's say you have forgot to ask about lump or bump in the groin. In here, you can ask it, and that will cover incarcerated hernia. So have you noticed any lump or bump in his tummy or in the groin? For intussusception, does he draw up his legs while crying? Does he turn pale while crying? So first thing you need to find out that, do you think your child is having intermittent screaming or crying episode? If they say yes, then your next question you ask, does he draw up his legs while crying? And have you noticed that he turned pale or blue during crying? Let's say a specific finding for intussusception. They have an intermittent screaming because intussusception is like one gut into another. So whenever the gut doesn't get enough blood supply, the child starts to get severe pain and child cry at that time. And again, that kinking gets better, and then child gets totally normal. And again, the obstruction happens, child starts crying again. During the crying, it looks like the child is in severe pain. So they draw up their leg up to the chest. Sometimes even they clench their fist, and it looks like they're in severe pain because they can't tell it to you. Then this is actually one of the way to know that they're in severe pain. So that covers all of your differential diagnoses related to GIT. If we go back to GIT causes, gastroesophageal reflux, there is not much of a specific feature for it. So they just come to you with vomiting for a prolonged period of time. And they say that the vomiting is after feeding, and child is growing well, developing well, everything is fine. So that's gastroesophageal reflux. So there is nothing to add for this in your question. Pyloric stenosis, we have already asked, that projectile vomiting, and also you will find out child is losing weight. Duodenal atresia, again, nothing to ask specifically. Incarcerated hernia, we asked about lump in the groin. Intussusception, we find out about intestinal obstruction, gastroenteritis, and also for esophageal atresia or tracheoesophageal fistula, it depends on the age of the child. We will come to this when we discuss these cases. So that means that if you just ask questions of intestinal obstruction, intussusception, incarcerated hernia, that will cover your GIT. Then don't forget about UTI and other infections. So for septicemia or meningitis, ask about any fever, rash. Depending on the age of the child, you can also ask headache, any neck pain or stiffness. Does the light hurt his eyes, which is photophobia? So depend on if the child is able to say these symptoms are present or not. But for every child, for septicemia, we should ask fever, rash. For otitis media, any discharge from his ears, any painful ear. Again, always in pediatrics, have a look on the age of the child. A 18-month-old will not be able to say, I'm having pain in my ear. But a 4-year-old might be able to say, I'm having a pain in my right ear. So depending on the age of the child, your question will be different. If a 10-year-old boy coming to you with vomiting, and if you ask mother, have you noticed there is reduced number of wet nappies. So that will become a very silly question, right? So everything, you need to always use your sense that what I'm asking. For otitis media, we ask ear pain, ear discharge. If it is like a very small child like neonate, we can also ask, have you noticed he is pulling his ears lately? For pneumonia, any cough, shortness of breath. So that will cover all the differential diagnoses that you need for this case. Okay. And every pediatric case will be finished with well baby question, binds, TMAC, past medical history, and family history. Now, this will be more discussed in our respiratory class, that what is well baby, binds, TMAC, and everything. But I will give you a basic idea that what normally we ask. But if you are looking for the note is actually given in the respiratory system. So well baby question, it includes mental status of the child. Then we ask about pee and poo. We also ask about feeding and sleeping. And we ask about weight. So these are the well baby question. So for well baby question, so for mental status, we ask, do you think your child is active, irritable, or lethargic? Any child who is lethargic and drowsy, we are always concerned. Especially vomiting child who is drowsy, we should not forget about possibility of a septicemia. How is his pee and poo? If you already asked it, which you have done in this case, then you don't need to ask it again. How about his feeding and sleeping? Feeding, sleeping is not super important because you are already talking about vomiting in this case. So it's not very important for this case, but there are some cases where we will ask it. And have you noticed any change in his weight? Especially, is he losing any body weight? Very important finding is this one, because weight loss in a vomiting child, we should be concerned about something serious, especially pyloric stenosis. So don't forget about the weight. So mental status, pee and poo, feeding and sleeping, and weight, that's your well baby question. Then we go to the binds. Binds is a mnemonic for number of things that we ask in a child. B is for birth history. I for immunization or vaccination. N for nutrition, means the dietary habit of the child. D for development. And S for support or social history. So this is binds. So again, relevant questions. It doesn't mean everything we need to ask in everywhere. So for a child who is 2 years, 3 years, we should find out the birth history. For a child who is 12-year-old, birth history is not super important. So what we ask in here, so how was the birth of the child? Was there any complication? Was he a term or preterm baby? Okay, just 2 or 3 questions. There is a lot of questions in this birth history, but for this cluster, we will be just asking, how was the birth history? Was there any complications during pregnancy, during delivery, or after delivery? Then you can also ask that, was he a term or preterm baby? Okay. After that, immunization. Is he immunologically up to date, or did he have all the vaccinations? So any of these 2 questions is fine. So you can say that, is he immunologically up to date? Or you can also ask, has he had, or you can say that, did she have all the vaccinations? For nutrition, we don't need to ask these questions in here. That's not important. Development is very important. So how is her growth and development? So we should find it out. If a child is not having appropriate growth and development, we are always worried about it. Social history, We find out the family situation, who is taking care of the child. Now, for a vomiting child, social history is not very important. Okay, so important is birth history. So how was the birth of the baby? Was there any complications? Was he a term or preterm baby? Is he immunologically up to date? How is his growth and development? That's it. Then we come to TMAC. TMAC is a mnemonic for travel history, medication, allergies, and contact. So for vomiting, yes, we can ask about travel. So any recent travel to anywhere? Is he on any medication? Any known allergies? Does he go to childcare? Has anyone in childcare has got the same complaint? Anyone at home has got the similar symptom? So in contact history, we try to find out, does the child have any contact with someone who has similar kind of issue? So does the child go to childcare? If it is 4 or 5-year-old, you ask, does the child go to school? Anyone at school having similar complaint? Same with the childcare. And also ask about the home. Anyone at home has got similar complaint. So that's TMAC. Any other past medical or surgical history, any family history of any chronic or long-term condition. So that will be your history for this. If I give you the summary of this history, so first of all, you greet, introduce, reassure. If it is an acute onset vomiting, ensure child is vitally stable. Then you ask the vomiting questions as a whole. You can ask the associated symptom or not, doesn't matter, but don't forget the differential diagnosis. Start with the bowel and waterworks. Then you can ask intersusception question, incarcerated hernia question, and then the non-GI causes, which is meningitis, otitis media, and pneumonia. And lastly, finish with well baby, binds, TMAC, past medical and family history. All clear for everyone? Any questions so far in the history? Diabetic ketoacidosis for a child is not our first line diagnosis. Okay. We will only think about it, especially if a child had a family history of type 1 diabetes, then only we would think about it, otherwise no need. No question, guys? Everything good? Birth history, usually, again, it is relevant and it has to be changed case by case. For a vomiting child, birth history is important. But if it's a 14-year-old, 12-year-old, so I would say that above 8-year-old, I would not be very bothered about birth history. But if an 8-year-old coming to you for a ADHD assessment, then birth history is still important. So it's always case by case, depending on what we actually looking for in the birth history, we will ask it if it is only needed. Moving on to urinary tract infection. A mother came with 9-month-old female baby with fever and vomiting for the last 2 days. You are a GP. History, physical examination, diagnosis, and management. So you've got a 9-month-old female baby with fever and vomiting for 2 days. So it's an acute onset vomiting. Your history should be the same thing. Now, in this case, you have got fever and vomiting both. So first of all, you use the same approach, just like how we introduced. Then you have got 2 complaints, fever, vomiting. Ask about, I understand your child has got both fever and vomiting. Which one came first? If fever came first, ask about the fever in detail. So when did it start? Is it continuous or on and off? Any chills or shivering? Did you measure the temperature? If yes, what was the highest temperature? Have you tried any medication? Did it help? Then ask vomiting question, just like we did. And then if it is a febrile child, we are supposed to asking all the fever source question. That means we need to find out from where the fever is coming. So fever source is very important to find out from head to toe. Okay. So what we normally do in this situation, we start from the meningitis. So any rash, any vomiting, we have already asked. So any rash, any headache, any neck pain or stiffness based on the age of the child. For a 9-month-old, we will only ask about any rash. For otitis media, you know what to ask. Viral upper respiratory tract infection, what we normally ask that any runny nose, any sore throat, okay, and any watery eyes we can ask. Then you go to the pneumonia. So ask about any cough, difficulty breathing, noisy breathing. And then you have got bowel and bladder. So you ask the bowel questions and bladder questions from here. After you have done it, then you go to the GIT causes. So see that the thing is that this child has got fever. So we will be mainly focusing on finding the cause of the fever. Okay. So you start with the fever and vomiting questions, followed by head to toe fever source question, starting with the meningitis. So depending on the age, we might be asking all the questions of fever, rash, neck pain, stiffness, photophobia. Then we have got ear, nose, throat. Then you have got lungs. Then you have got bowel and bladder. So these are the areas from where a child can get infection. After that, you just finish with all other GIT differential. So incarcerated hernia questions, intersusception. So same like others. When you come to the past medical history, now from the history, if you think that this is a urinary tract infection, especially you might get a child crying while passing the urine or while changing the nappies. The urine is more smelly these days. You might be thinking about a possibility of UTI. And then in the past medical history, just ask directly any previous history of urinary infection or any kidney disease, family history of kidney disease. It only you can ask it if in the history you think that this is a likely case of UTI. Otherwise, you just ask like any past medical or surgical history, any family history of any long-term condition. So that's your history. Now, history is pretty much same. It's just we just twisted the history in a way so that it looks we are actually doing it as it should be. I always say that there is no specific way of asking questions. How the patient presents to you, you need to focus on that. If a patient only comes to you with vomiting, you will start with the vomiting question and then start GIT question and then you go to the non-GIT question. But when fever is there, you should start with the fever questions. So fever, vomiting, followed by all the fever source question, and then you ask the GIT causes. So you just turn it over, but still it's the same questions. Physical examination. Now we are discussing the physical exam of a vomiting child, and you will be able to use this one in any kind of vomiting cluster. So physical examination, we will start with the general appearance. So on general appearance, does the child look active, alert, or drowsy? Any dysmorphic feature of Down syndrome? Ask pickled, so any pallor, icterus, any sign of dehydration. If you forget to ask dehydration in a vomiting or diarrhea child, that's a very bad sign. And most of the time, examiner doesn't like it. So dehydration is very important. So any sign of dehydration, many times, especially in face-to-face, examiner can ask you that, what are you looking for in this child for dehydration? Then you have to ask capillary refilling time, skin turgor, sunken eyes, dry mucous membrane, and depressed anterior fontanelle. So these are the things that we look for to assess dehydration in a child. So capillary refilling time, skin turgor, very sunken eyes, dry mucous membrane, and depressed anterior fontanelle. Ask about any rash, and then don't forget about vitals. If they have given you in the stem, or if you have got it from examiner in face-to-face, then you don't need to ask it. But if you haven't, then you have to ask all the vitals. Don't forget about growth chart. In pediatrics, every physical examination, you should ask for a growth chart. Why in vomiting cluster it is must? Because it might help you to differentiate between reflux and pyloric stenosis. Because if the child growth chart showing that child is not growing appropriately, likely chance it's not a reflux, it is a pyloric stenosis. So that's important. So you just ask the examiner that is the growth chart available. Normally you never need to plot it. There is just one case where you need to plot it. And when we discuss that case, we will discuss growth chart in detail. But usually in the exam, the examiner will say the growth chart is within the normal value according to his age and sex. Then after growth chart, we go to the ENT exam because child has got a fever and vomiting. So ENT examination, again, when we discuss the ENT in our class, then you will get to know more about ENT. We are not going into detail today, but in here we will be just looking for in the ear any tympanic membrane changes or any ear discharge. In the nose, any nasal discharge or any nasal mucosal changes. And in the throat, any tonsillar exudate or any tonsillar hypertrophy. So that's mainly looking for any infection in ear, nose, and throat. Any child who is having fever and vomiting, never forget to ask about neck stiffness. Less than 18 months of age, neck stiffness usually it doesn't give you any information. After 18 months, neck stiffness should be asked. And now, after you have done that, then you go to your systemic exam, starting with the focused abdominal examination. So in the abdominal exam, you do inspection, palpation, and auscultation. On inspection, you are looking for any visible distension, any visible peristalsis or visible mass. Visible peristalsis can be found in pyloric stenosis child. On palpation, any palpable mass or any tenderness. On auscultation, is the bowel sound audible? Then you should say, with the consent of the parent, I would like to check hernial orifice, genital examination, and perianal inspection for any blood. All of this has something to do with your vomiting. Hernial orifice, we know that there is a case of incarcerated hernia, so we should ask it. Genital examination for torsion of the testis. Perianal inspection, not DRE, it's just the inspection for, especially we'll be doing it for any kind of blood. So if a child having intersuccession, sometimes you might be able to get a parectal bleeding. So that's only thing that you are looking for in the perianal inspection. And at the end, you say that you would like to do all other systemic exam. And if there is any office test available, which is urine typistic and BSL. Urine typistic, we look for leukocyte, nitrite, RBC. Again, BSL we always ask in a sick child. So that's all the physical examination that we are supposed to ask here. Okay. Now you might be wondering how I should ask it. I have already discussed it in our few other classes, especially the cardiology ones. If you have missed that class, please make sure you do that to understand how the physical examination should be asked. Okay. So there are different ways in face-to-face and online. In face-to-face, we ask it from examiner, and everything that we ask, examiner will give a finding after we ask it. In online exam, they don't answer anything, so you don't need to ask anything from examiner. One, that they can just give all the finding on your screen and you just need to read it. Or they might ask you that discuss what physical examination you are going to do with the examiner. And after you have done that, the finding will appear on the screen. So in such case, you just discuss that these are the things that I am looking for in this child. After you have done it, the screen will show the finding. Okay, is this clear for everyone how this physical examination should be done? Dr. Mariam, if two complain in a STEM, which cluster we should follow? Now, if someone has got fever and vomiting, it is still vomiting cluster. Okay. So you have to find out like which cluster it goes. And most of the time it is not very hard to find out. If the cause of fever become obvious after few questions, should we ask all DD question? Yes, DD is must. In any case, even if you got the finding, you have to ask most of the differential diagnosis. Yes, Dr. Pawan, in online exam, you have to say that I'm going to do this examination line by line. That's right. Now, one of you asked that what to do in face-to-face. So I would rather say that in face-to-face, you will say that, dear examiner, I would like to do physical examination on my patient. First, starting with the general appearance. Is the child active, alert, or drowsy? Then examiner gives you the finding. Any dysmorphic feature of Down syndrome? Examiner says no. Any pallor, icterus, or any sign of dehydration? Examiner says no. Any rash? No. I would like to know about the vitals, pulse and blood pressure, please. Examiner will give it to you. And also how about the temperature, respiratory rate, and saturation? Examiner, is the growth chart available? Examiner can say anything. Then I would like to do a ear, nose, and throat examination. Starting with the ear, I would like to know if there is any tympanic membrane changes or any ear discharge. Examiner says no. Any nasal discharge or nasal mucosal changes? No. And then you ask the throat question. Any neck stiffness? No. Examiner, I would like to now do full body systemic exam, but starting with abdominal examination. On inspection, any visible distension or visible peristalsis or mass? No. Any palpable mass or tenderness? Is the bowel sound audible? With the consent of parent, I would also like to check the hernial orifice, genitalia, and paranal inspection for any blood. Examiners say all are negative. Then I would like to do all other systemic exam, including respiratory, cardiovascular, and central nervous system examination. Examiner says all are normal. Is there any office test available, examiner? Examiner can say, what are you looking for? I'm looking for urine dipstick and blood sugar level, please. Okay, this is how you're supposed to ask questions in face-to-face. In online exam, you will be just saying all of this at a time. And after you have finished it, examiner or the invigilator will give you the finding on the screen. That's right, Dr. Fatima. If examination findings are displayed on the screen, do we still say line by line? No, if the findings are given, then you don't need to do it. They will not ask you to do it. They will just say physical examination finding is on the screen. So you don't need to do anything at that time. You just read the finding and go to your next task. We say full. We never use short term in exam. We don't say CNS. We don't say ENT. Okay, we always say the full term. We don't say BP. All right, now moving to the management. So what you have found in this case, that the child having fever, vomiting, many times there is nothing else you will find in the history. And only thing that you will find out that when you asked for the office test, in the urine dipstick, there is some leukocyte or nitrite positive. That's more than enough for your diagnosis that it is a urinary tract infection. Okay, symptoms might not be that much evident in children. So how we are going to explain urinary tract infection in a 9-month-old? So from history and physical examination, most likely your child is having a condition called urinary tract infection. Do you know what it is? Most of the patients know what is UTI, but still you say, well, it's an infection of the urinary tract caused by a bug or bacteria. Let me draw a picture for your better understanding. Now, if it is online, you don't bother with drawing. You can just say that, well, our urinary tract is made of kidney on the top. Then there is a connecting pipe which goes to our bladder or water bag, which is what we call as ureter. And from the bladder, it goes out of the body by the water pipe or urethra. Now, because the urinary tract is very close to the back passes in female children, bugs can easily enter into the tract, causing infection, which actually manifest as fever, vomiting, and sometimes with a painful, smelly urination in child. If you are face to face, then draw the kidney very quickly, draw the ureter, bladder, urethra, okay? But for female, just finish with the bladder, urethra, those things you don't need to draw. So just say that your child most likely suffering from urinary tract infection. It is an infection of the urinary tract caused by a bug or bacteria. Now, let me explain it in detail. So we have got kidney as part of our urinary tract, and then there is a connecting tube, which we call water pipe, or you can say that, just say that, well, we have got kidney as part of our urinary tract, and from that, the urine will travel to our water bag or bladder through a connecting pipe known as ureter. And then from the bladder, it goes out of the body by the water pipe or urethra. Now, because this tract is very close to the back passes, bugs can easily enter into it, causing infection and inflammation, which manifest as fever, vomiting, together with painful, smelly urination. Do you understand me so far? Yes, doctor. Now, because your child is still 9-month-old, and this is considered to be a part of the vulnerable group of child, I would like to send your child to the hospital. Now, for a UTI, if the child is not septic, you don't need to send them by ambulance. If the child is having high fever, looks very drowsy, vomiting, that means it's a septic child. Then you need to send the child by ambulance immediately. So depending on the severity. So I need to send your child to the hospital. In the hospital, she will be seen by a child specialist for further evaluation and management. As the urine dipstick that we have done today is just a screening test, and sometimes it can be contaminated as well. In the hospital, they also might want to take another urine sample, probably by a method called suprapubic aspiration. And by taking that urine sample, they will also send it to the lab to do a culture to find out the exact bug that is causing this infection. In this procedure, a small needle will be passed just below her belly button, and then a sample of urine will be collected from there. Please don't get scared. It is totally pain-free and will be done by a very experienced doctor. It is important to do it because children in this age, they can't void on request. And many times, the urine actually can be contaminated with their pores. So we need to just make sure that this is actually a urinary tract infection before we give her antibiotics to treat it. Are you understanding me so far, Janie? Yes, doctor. Once they have taken the urine for culture, the specialist will start your child with an antibiotic to fight the infection and Panadol to reduce the fever. Now, many times, it depends on the specialist if they want to do further investigation or not. For the first time urinary infection, normally they don't go for any further investigations, especially for recurrent urinary infection. The specialist might want to do a little bit more investigations or imaging to know about her urinary tract. But again, it's the specialist decision what they want to do. So in case they want to do further workup to know the cause of infection, they might want to do a ultrasound of her urinary tract to exclude any structural abnormality which can cause this infection. In some children, specialists might also want to do another test called micturating cystourethrogram, where a special dye is inserted into the urinary tract to look for any abnormality. But as I said, that first-time infection, these are not usually done, but specialists might at least want to do an ultrasound to rule out any structural abnormality. Please don't get stressed. It is not an uncommon condition in female child. And most of the children with urinary tract infection doesn't have any underlying abnormality, and they make a good recovery without any complications. Once she is discharged from the hospital, please come for a review with me. I would like to review her and discuss about the urinary tract infection in detail with you. Please make sure you always wipe from front to back and give her ample amount of fluid. I'll give you some reading material. You can read that on the way to the hospital. And as I said, I will review you once she's discharged from hospital. Okay, so that's how you finish. So 4R is basically a finishing thing that we use, reading materials. We give red flags if we are sending the patient to home. If we are sending the patient to hospital, no need to give red flag. Review, that when do you want to review her, and refer. So in this case, you referred her to hospital, you talked about review, you have given her reading material. That's enough. Okay, so that's what we do in urinary tract infection. Please remember one thing, that a lot of examiner, they like that you talk about these ultrasound MCUGs, and there are examiner who doesn't like about it. It's a very tricky situation. But if you follow what I said, that I actually say that this is the specialist decision if they want to do it or not. But I just discussed it. So if there is an examiner who wants to know about it, they will know I know this. Okay, so just use in this way. You don't say that this will be done, obviously. You just say that, well, in some cases, especially in recurrent urinary tract infection, the specialist might want to do further investigations to look for any structural abnormality of the tract. So it can include an ultrasound most of the time. If ultrasound shows any abnormality, they can also do a dye test called this MCUG, and then they discuss what is that. So that basically the treatment is first discuss what is urinary tract infection, explain why you are sending the child to hospital, because child is less than 12 months. Any less than 12-month child with fever, vomiting, having any infection should be sent to the hospital for further evaluation. After 12 months, this same child, you can treat it as in your outpatient clinic. Then you have to talk, any less than 12-month child, they need suprapubic aspiration for confirmation of UTI. After 12 months, you don't need that. After 12 months, you can either get a clean catch urine, so that the parents can try to catch the urine while child is urinating, or in case of 3 to 4 year old who can void on request, you can just do the MSU, which is the midstream urination. Okay, but for less than 12-month old, you have to send them to a hospital for suprapubic aspiration to confirm it. And then once the culture has been taken, antibiotics should be started. What antibiotic usually we use for children? For children, basically either trimethoprim or cefalexin. Trimethoprim for 3 to 5 days and cefalexin for 5 days. Then you have got this further investigations that you can discuss, and lastly finish with some reassurance and red flags, reading material. reading material, review and referral, 4R. That's all that you need to do in this case. Any question, guys? In GP clinic, we can't do it. For a 9-month-old, we can't do anything in a GP clinic. So that has to be go to the hospital. For more than 12 months, we don't need to send them to hospital for UTI unless they don't look septic. If they look septic, yes, you have to send them. If they don't look septic, then no need. You can treat them with just oral antibiotic. Do we need to do follow-up culture? It depends. If the hospital did not make any follow-up with the child, then yes, when they come to the GP, you actually look at the culture result that if the child has got the right antibiotic or not. But you don't need to go in that much detail for exam. At the moment, you are just treating the UTI. You don't need to think what will happen after hospital discharge. That's in the next appointment. Any less than 12 months, yes, we will refer them to the hospital because they can get septic quite easily. And especially you can't do a suprapubic aspiration in your GP clinic, so you have to send them. Moving on to gastroesophageal reflux. If fever and vomiting, don't we have to think of the conditions which come with both intussusception, etc., no fever? As I said that, guys, you guys are making it more complicated in your head. I can understand. The case is very simple. When a child comes with fever, vomiting, we try to find out mostly the infectious cause of the fever, vomiting, which means our main focus will be on first asking the fever questions, vomiting questions, then find out head to toe from where the fever is coming. If you do that, that's more than enough to pass the exam. But in any children, we try to find out the GIT causes as part of a format. It's must, because you can't just think that, well, the child cannot have anything else just because the child has got a fever. We are always looking for intussusception, we are looking for intestinal obstruction, even though the child has fever. Now, the thing is that why we kept it later, because that's not very important. But for a child who doesn't have fever, just have vomiting, we kept GIT causes at first because that's more relevant. So the most important things we are going to ask first. If you think you are running out of time, then you can always skip the less important things. Okay? Yes, even if it is more than 12-month child, any recurrent UTI children will have these investigations. So it doesn't bother or doesn't mean that you are not going to do investigation if it is a more than 1 year old. Any child who has got recurrent UTI, they will have ultrasound and then a AMC as part of the assessment. What I would suggest all of you to do that, please also go to the RCH guideline of urinary tract infection, and also you should be able to get a lot of other informations about it. No, suprapubic aspiration is only for children less than 12 months. Okay, move on. You will not be able to finish this vomiting cluster today. You are a GP and a mother brought her 4-month-old baby girl. She says that child vomits after feeding. There are no other symptoms. Mom thinks that the bottle feeding will be better for him. History, physical examination, diagnosis and management. So it's a 4-month-old who is vomiting after feeding, no other symptoms, and mom thinks bottle feeding will be better. Now, gastroesophageal reflux doesn't come as just like an acute onset of vomiting. It comes like there will be a history of this reflux even after birth. So for a long time, this will go on. Gastroesophageal reflux and gastroesophageal reflux disease is different. So reflux is just a physiological thing which happens in every children less than 12 months. So it is the passage of gastric contents into the esophagus. So it's a physiological process that occurs several times a day in a healthy child. It's very common in infant, and most of the time it will resolve on its own. By 12 months, only 5% children will have a reflux. So this is just physiological phenomenon because children lower esophageal sphincter is not mature enough. Easily food can go up from stomach into the esophagus, which is normal. But when a child who has reflux, they also has got this associated finding that's pathological, and that is what we call as gastroesophageal reflux disease. So what are those? Pronounced irritability with arcing of the back, refusal to feed, weight loss, hematemesis, chronic cough or wheeze, and apneic episodes. So that means with the vomiting cluster that we are going to ask for this child, we need to also add these red flags, just to know that if it is a case of reflux disease or not. Okay, so the positive point in the history will be, so child will have vomiting after feeding, white color, so all the milk is coming up. Now remember that is projectile doesn't mean it is always pyloric stenosis. The important thing is that child is gaining weight. If child is gaining weight, it's not pyloric stenosis, that's reflux. In reflux, every physical examination will be normal, and you will be asking about all the signs of reflux disease. So what will you do? Pronounced irritability. So irritability, you will be able to find out in the mental status question, like does the child look active, irritable, or drowsy? You will be asking how is he sleeping and feeding. So that will also answer this question. Weight loss, you will be asking. You will in the CC view, you will ask about any blood in the vomiting. So everything is in the format already. You will be asking about the cough as part of the non-GIT cause of vomiting. Just the two things that is not in the format is wheeze and apnea. You should ask that, have you noticed that your child having any arcing of his back lately? Have you noticed any wheezy sound coming from his chest, like a musical sound? Have you ever noticed that your child stopped breathing for a few seconds while sleeping? So these three questions you will add in the vomiting cluster for this particular case, and that should cover everything. Okay. History physical examination is same, just add the symptom of reflux disease, and that should be fine. So coming to the management for reflux. So most likely from history and physical exam, your child is having a condition called gastroesophageal reflux. Let me discuss it in detail. Depending on is the face-to-face or online, you can draw a picture or not, but let me just discuss it with you. So you can say that this is your child's food pipe, which gets connected with the stomach. Okay, you can say that the lower part of the food pipe, where it gets connected with the stomach, is poorly developed in neonates or babies. That's the reason why milk in the stomach flows back into his mouth, especially when you put him down. It's a very common condition where baby vomits after his feed, but otherwise they thrive well, gain weight well. Condition usually improves by the time they start the solid food, and most of the time it is cleared by 1 year of age. But it could be due to other condition as well. Then try to give some differential diagnosis here and say why it is not likely possibility. You don't need to do any investigations if the history seems to be a reflux. As part of the management, you have to say that the management is mainly lifestyle modification, So first of all, I would advise you to follow some steps. So one, try to give him a small frequent feeding. Decrease the duration of feeding along with the time in between. You can also add some food thickeners, like sometimes you can add Gaviscon that will also relieve this problem. You can also elevate the head of the cot by 10 to 20 degrees. And after each feed, please do not put the baby immediately to sleep. Carry him for a while and put him on cot with the head elevated. We highly recommend breast milk because it is best for baby, and changing it to formula will not resolve this issue. Why I have added this? Because look at the question. Mom thinks bottle feeding will be better for him. Now, this is one thing a lot of candidates forget, that if something is written specifically on a stem, you have to always address that issue in your explanation. Sometimes they say that I think I have cancer in medicine question. Sometimes in pediatrics, they say, I think my child has got lymphoma. So if you don't address that part in your management, then one key step is missed. So that's why in here, the parents says that they think the breast milk is the issue. So you have to say that we highly recommend breast milk because it is best for the baby. If that doesn't help, even after you have tried everything, then I can always send him to a pediatric gut specialist who can start him with some acid suppressant therapy. Most of the time it is not needed. Please don't worry, as long as your child is growing well, feeding well, there is nothing to be afraid of. I will review him regularly, and I will also give you some reading material about everything I discussed. If anytime you notice that he's getting very much irritable with arcing of his back, he stops to feed, losing his body weight, having cough, musical sound from his chest, or he has stopped breathing while he is sleeping, please come back to me immediately. Okay? Or any questions? Good question, Dr. Fatima. If breastfeeding, how to give thickeners? Like most of the mothers, not every time they do the breastfeeding, they sometimes pump their breast milk in a bottle and then they give it to their child, right? It's a combination of both. So during that time, they can add some thickeners, not obviously not with the breast milk, but that doesn't mean you will advise them to go for a formula milk because you can add some thickener. If it is a gastroesophageal reflux disease, that needs to be sent to the pediatric gut specialist or pediatric gastroenterologist who will do further assessment of the child, and most likely they will put the child with PPIs. Okay. Thank you. I will just stop sharing for 5 minutes and then we will start. Okay. All right, everyone, let's start again. Pyloric stenosis. Pyloric stenosis is very important cause of vomiting in a child. So you are an HMO in ED, a 6 weeks old baby presents with parents with vomiting. So mother brought 6 weeks child. So 6-week child, this is actually a typical age group who comes with pyloric stenosis. So history, physical exam, diagnosis and management. Positive point in the history is that the child started to have vomiting for the last few weeks or days. The onset of pyloric stenosis is from 2 to 6 weeks of age. This is the main age group. Very rare after 12 weeks, but still after 12 weeks, it can happen. Vomiting is non-bilious, which means it's not a bile-stained vomiting. Progressively, the vomiting becomes more and more forceful and projectile. Child becomes hungry and cries immediately after feeding because everything is coming out, and child will have weight loss. So if a child presents to you with a projectile, forceful, non-bilious vomiting, and they are losing significant amount of body weight, that's the time we will be thinking about pyloric stenosis. Physical examination, child can get dehydrated because it's a frequent vomiting. You might also be able to find out visible gastric peristalsis. You can also feel for a pyloric mass. So it's just when you ask for the inspection palpation, you might be able to get this finding. So visible gastric peristalsis, then feeling a pyloric mass, which is best felt in the right upper quadrant. And they say it's an olive-shaped mass. Sometimes, if it's in the face-to-face exam, you can also ask for a feeding test. What is feeding test? So you ask the mother to feed the child, and you actually look at what happens after feeding. Does the child immediately vomit, and the vomiting is forceful, projectile or not? So feeding test can be done as well. Not mandatory for the exam, but still you can ask for it. So you just follow the cluster with the history, physical exam, totally same. You just need to know the management. So most likely your child is suffering from a condition called pyloric stenosis. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So you can draw quickly about the stomach and the pylorus. If you can't draw it, that's fine. You just explain it. So you can say that milk goes from the mouth through a tube-like structure called food pipe to the stomach. From this stomach, milk then goes to the small gut. In pyloric stenosis, the lower end of the stomach, called pylorus, get narrowed. And as a result of that, the milk or whatever the child drinks, it cannot pass down to the small gut. So everything that your child having is accumulating in the stomach, it gets filled, and then your child vomit it out. Now, because of his frequent vomiting, everything that you are giving to him, it's not going to his gut and it's not absorbing. So he's not gaining weight, and with the vomiting, he is losing fluid from his body, making him dehydrated. This is an emergency condition, and I'm afraid that an operation is needed to fix it. I'm really sorry to tell this to you. I can't even understand how bad you must be feeling right now. But I want you to know that this is the right thing to do at the moment. And I really appreciate that you are here to discuss about it. I'm going to call the ambulance and also call the hospital pediatric team so that they are aware of him. And I will arrange for a pediatric emergency retrieval team who can take him to the hospital as an urgent basis. In the hospital, your child will be seen by a specialist for further management. Diagnosis is usually clinical, but they might want to do an ultrasound to confirm. They will do frequent blood tests to check his salt and mineral balance. As your child is dehydrated, in the meantime, while we are waiting, I'm going to start him on IV fluid through an IV line as well. Please don't feed your child from now onwards because it can make the vomiting worse. If your child keeps on vomiting, even after you have stopped eating, they might also want to insert a tiny plastic tube through his nose down to his stomach, called nasogastric tube, to remove any contents of his stomach to stop this vomiting. Once your child is stable, after giving the fluids and everything, most likely the specialist might want to go for an operation to fix this problem. I know that this is not something that you want to hear. I know that this is very scaring for you, but I want you to know that this is not a very uncommon condition and it is quite fixable after surgery. Your child will be able to start eating, drinking within 6 to 8 hours after operation. And once it is fixed, it is unusual for it to come back again. I want to reassure you that your child is in the best hand and the specialists are going to do their best to make sure he's normal and fine again. I'm going to give you some reading materials. You can go through that while you are going to the hospital. And I would like to review him after he is discharged from hospital. Do you have any questions? Okay, so that will be your pyloric stenosis management. The explanations are pretty good. If you can follow this in every management, you will be fine in the exam. See that time to time, I always add some reassuring sentence in between. Those are the most important things. You always are supposed to reassure a patient and also the parents. Any question with this one? We don't need to mention the name of surgery. You just say that surgery is needed and a specialist will discuss. All right. Moving on, intersusception. You are a HMO in emergency department, a 5-month-old boy with multiple episodes of screaming for the last 6 hours. Has vomited twice in the last 3 hours. History, physical exam, explain the mother the condition and further management. So it's a HMO in ED, 5-month-old boy, multiple episodes of screaming for the last 6 hours. So this is what will you think? Either it's a case of incarcerated hernia or intersusception. Now, screaming can be due to a huge number of causes. Just because there is screaming or crying doesn't necessarily mean that this is a case of intersusception, but that's one of your differential diagnoses. So you have got screaming and vomiting. So that will be your history of presenting complaint. So start as we do always, and then start with the screaming question. So can you tell me a little bit more about this screaming? We need to know since when. Is it continuous or episodic? Anything particularly happened before this started? Like child can have a foreign body, child can have a fall, child can injure themselves. So anything can happen which can start the screaming. So we need to find that out. How many episodes so far? Does he draw up his leg while crying? Or have you noticed that he also clenches his fist while crying? And does he turn pale? This is a very important question for intersusception. After that, you will ask all the vomiting questions, then the differential diagnosis questions one by one. For intersusception, only other question you will ask is that, have you noticed any loose stool or any red colored stool? This child can get a red currant jelly-like stool. So that's why we are asking these questions. It's not always that you will get it, but in some children, you can get it. Okay, so the differential diagnosis questions are same in here, just like we have done. And then you finish with everything like before. Coming to the physical exam, same physical exam, the finding that you will be looking for, you can get distension of the tummy because intussusception is basically a kind of an obstruction. On palpation, you can get a sausage-shaped mass. Now, one thing I say that in the exam, if it is a face-to-face, you have asked that on palpation, any palpable mass or tenderness. Examiner says no. Don't stop it. If you suspect it is a case of intussusception, ask that I would also like to see that if the child cries, then can I feel a mass? Then sometimes examiner says yes, when child cries, you can feel a sausage-shaped mass. Because that's most of the time in intussusception, when child cries, then you feel it more. Ask some of the other questions. Any empty feeling in the right iliac fossa? Any tenderness? So emptiness in the right iliac fossa, tenderness is also positive in this case. You can get alternating area of high-pitched bowel sound with absent bowel sound in here. So these are the findings that you will be looking for in abdominal exam. Don't forget about checking the perianal area for any red currant jelly. Now, the positive points you already know that what we are looking for. Physical examination also you know, so that's fine. Management. So you will explain based on the history and physical exam, most likely your child is having a condition called intussusception. Do you know what it is? Now, describing intussusception is very hard. The easiest way is to draw the bowel and draw another bowel in there. So it's a telescoping of one gut into another. So you say that, Will, the intussusception is sliding of one part of the gut into another. Because of sliding, the bowel can get blocked or obstructed, leading to pain and vomiting that he is getting. Now, what happens in this condition that when the bowel gets blocked, the part of the gut that is blocked will not get enough blood supply, and it can become totally non-viable, which can become very much life-threatening sometimes. So that's why it is an emergency condition. I need to admit your child to the hospital and involve the child specialist. So this is an ED case. So you are just admitting the child and involve the child specialist. Because you are a junior doctor, also you say, I will also involve my registrar who is going to come and have a look. In the meantime, please do not give him any food. We will put an IV line and start him on IV fluid. And also we will take some bloods to make sure his salt and mineral balance are good. The specialist will come and review him and might want to order an ultrasound and X-ray of his tummy to rule out any associated obstruction of the gut. Once it is confirmed that it is a case of intussusception, treatment is usually given as a combination of management by the gut specialist and a radiologist and a pediatric surgeon. Most of the time, they will go for a particular procedure called air enema, where a small tube will be passed at his back passes through which air will be passed. And with the air, most of the time, the slided or blocked gut will be untwisted again and the pain will be relieved. Please do not worry. Throughout the procedure, your child will be monitored by the specialist and he will be in sleep, so he will not get any pain. If this procedure isn't effective, then the last option will be surgery. But I would like you to know that most of the time, this procedure is very much effective, and I hope that your child will be fine after that. Please don't get stressed. Now that you are here, we will give our best management to make him as comfortable as possible. Do you have any questions? You can give some reading material to the mother, but obviously it's in the hospital. You are admitting the patient. You don't need to refer the patient to anywhere. You don't need to give red flags straight away. Okay, just one thing that you can do is giving reading materials. Even if you don't talk about this 4R in hospital patients, it's totally fine. Clear everyone about the intersusception? Now, intersusception, it's a case in RCH. Please go through the RCH as well. Same with pyloric stenosis, urinary tract infection. I would advise you to just to read the RCH for once, because this gives you a up-to-date idea about these conditions. Just read it just once. It's not like you need to memorize anything. Everything is written in the notes, but at least just get an idea, because time to time, if the scenario gets changed, then you would know what to do. Any question, guys? Okay. Yeah, RCH. You must have read it during your MCQ preparation as well. So, incarcerated hernia, a 5-month-old baby came to your GP clinic with his mother because of sudden onset intermittent screaming with few episodes of vomiting. Now see that it's exactly looks like the case of intersusception, but it's not. So that's why I say always keep your mind open in the exam. Older brother has got recent onset gastro. So that means they might be also giving you some trouble to make you more confused. Just because brother has got gastro doesn't mean this child also has got gastro. Okay, that's one type of question. The another type is that 3-month-old having very irritable for 3 weeks. Today, mother noticed a lump on the inguinal area or groin area. That's a straightforward case. Now, this case, which is for 3 weeks, might be a reducible inguinal hernia. But the one of this one, which is a sudden onset screaming, that's not just a reducible hernia, that's an irreducible hernia complicated by incarcerated or obstructed hernia. Okay? So the history is same in here. Nothing is different from what we have learned. Only finding you might get that mother can say, yes, I can feel a lump in the groin area and that is very red and tender. Many times in incarcerated hernia, they say that they don't know about it, or they haven't looked into the groin of the child. So in history, you might not get any finding except child might have vomiting and the pain. So the history is same, physical examination is same, but when you come for the hernial orifice examination, then only you get a finding. So they can give you a picture of incarcerated hernia. The hernia will look very red. What you need to ask to the examiner, that examiner, I would like to know about this inguinoscrotal lump. So I would like to know the consistency of it. Is it tender? Is it reducible? Okay. And is the cough impulse positive? If it is a reducible hernia, then the hernia will be reducible, cough impulse will be positive, and it will be non-tender. If it is an incarcerated hernia, then the hernia will be irreducible, that's the first thing, absence of cough impulse, and it's very tender. That's how you can diagnose it's a case of incarcerated hernia. Okay? So explain in this way that from history and physical examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, let me explain in detail. So a hernia is a protrusion of part of the gut or fatty material through a weakness or opening in the tummy well. So you can say that you can even draw a picture of the tummy and you can say that, look, this is the tummy And a hernia is basically a protrusion of the gut or fatty material through a weak point in his tummy wall. And it usually seen as a lump or a bulge under the skin in his groin area. In a simple hernia, this content are able to move freely in and out of the defect. And that is what we call as a reducible hernia. But if the part of the bowel becomes trapped and it cannot go back to the tummy, the risk is that it will have its blood supply being cut off. And if it can't get the blood supply, that part of the gut can become non-viable, which can become a case of irreducible or incarcerated hernia. I'm suspecting that in your child case, this is the issue because I can see that the hernia is no longer going back. It's red, it's tender, and it's likely chance that it is an incarcerated hernia. So that's why it is an emergency condition. We need to admit your child, and I need to also involve my senior, and a child specialist will come and review him as early as possible. Please do not feed him or drink anything at the moment. We will put an IV line and start him on IV fluid. Most likely, a specialist will go for a surgery to put the blocked gut back inside. Please don't get scared. We will do our best to manage his condition. We have a very good team of pediatricians in here. I understand that when you came here today, you did not even think about it. But I really appreciate that you brought him here, and with the appropriate management, most of the time, the bowel becomes viable and there will be no more complications after we can fix it. Do you have any questions? Okay, so the explanations are not very much detailed because you are a junior doctor. You are not going to explain the surgery. You are not going to take the consent for the surgery. The specialist will come and discuss everything. They will do the surgical part. Clear, guys? Any questions? Okay, moving on to duodenal atresia. This is our last case for pediatric vomiting. Duodenal atresia is important for the exam. And in here, they give you an X-ray. So you are working in a small country hospital as a HMO. You have been called to talk to a 27-year-old mother who gave birth to a baby boy 24 hours ago. She started breastfeeding, but he has vomited several times greenish fluid and hasn't passed meconium yet. The neonatal checkup did not reveal any pathological finding, especially the anus was present. An abdominal X-ray is provided. Take a brief history, explain the X-ray finding to the mother, discuss the most likely diagnosis and management with the mother. Very classic question. So in this case, few things are important. It's a 24 hours baby who is vomiting greenish fluid after each feeding. The meconium hasn't been passed. 24 hours meconium hasn't passed. Will you be worried still, or will you wait for another 24 hours? you will wait for another 24 hours because we wait for at least 48 hours for the meconium to be passed. After 48 hours, if there is no meconium, then yes, we are very much worried. 24 hours is still okay, but the reason in here that child is not able to have any food down to their gut because there is an issue here. So they will not be able to pass meconium anyway. So let's see what we are going to do. So this is the X-ray given. The X-ray in here you see is called a double bubble sign. So this is one bubble and this is another bubble. So this double bubble sign is a classic picture for a case which we call duodenal atresia. Okay, 24 hours old, having vomiting, especially bilious vomiting. And if you get this double bubble sign, that's more than enough for you to diagnose duodenal atresia. 24 hours child, vomiting, but non-bilious. What will be your likely cause? Guys? No, esophageal atresia. Because esophagus is in the top part, so bile will not come over here. Bile means anything which happening after the stomach. So duodenum is a part of gut. So that's why in duodenal atresia, you are getting bile stain vomiting. So this will be a case of esophageal atresia plus minus tracheoesophageal fistula. So if 24 hours vomiting, but it's non-bilious, our likely chance is it's the esophageal atresia plus minus tracheoesophageal fistula. Very important to differentiate between these two. Both of these come in exam. So now 24 hours, vomiting bile, having abdominal distension, what will you be looking for? So two things. One is called jejunal or ileal atresia. How will you be able to differentiate duodenal atresia with jejunal or ileal atresia? Because both of them will have bilious vomiting. In duodenal atresia, there will be no abdominal distension. But in jejunal or ileal atresia, there will be abdominal distension. And yes, in jejunal or ileal atresia, there will be no double bubble sign. Okay, so that's how we differentiate. Now, brief history. In this case, it's the same history that we will be asking. It's a 24 hours old baby. So when you ask some history, be careful about what you are asking. So hemodynamic stability, ask about the mother. Like, I understand that you just delivered. How are you feeling now? Are you all right? Are you having any pain anywhere? So just ask just one question, that how are you feeling now? Are you okay? Are you having any pain anywhere? And obviously then you ask about the baby, reassure the mother a lot because mother will be very scared. So ask all the vomiting questions that we ask about most of the differential diagnoses in here. Okay, so it's the same history that we ask. For duodenal atresia, it's very important to know that if the mother had Down syndrome screening during their pregnancy. Okay, and also if the mother age is not given in the history, you can ask it that I'm really sorry to ask it. It's important for assessment. Can you please tell me, like, what's your age? Now, if you feel that, well, I would not like to ask the age of the mother, I will just ask that, have you had Down syndrome screening by any chance? Okay, so it's very important that you assess that, because most of the time, about more than half of the time, Down syndrome babies actually have duodenal atresia. Okay, so find that out as well. Apart from that, everything else is fine. The next task is explanation of the X-ray to the mom. When you explain something like this to the patient, you have to be very careful with simple way of discussing it. So you'll say, thank you so much for all the information, Jenny. I'm going to explain the X-ray of your baby's abdomen with you. If you don't understand me at any time, please let me know. So look that this is the X-ray of your baby's lower chest and the tummy. In X-ray, some structures are blackish, some are white. The white are mainly which is bone and which contains blood or fluid. And the blackish are which contains air. That's why this lower part of the chest that you can see on the both side is your baby's lungs that contains air. That's why it's looking black. And in the middle, it is his heart. Now, have a look on his tummy. In the tummy, you can appreciate that there are two big bubble-like blackish shadow. That is what we call as double bubble sign. Now, when we see something like that in the tummy, which it should not be, there is a likely chance that there is a possibility of a small gut obstruction in your child case. Now, a small gut, it has three parts, and the upper part of it is called duodenum. I'm afraid that most likely I'm suspecting, based on his history, it is likely to be a first part of the gut, which is called duodenum, and we call it as duodenal atresia, because I suspect that that part of the gut is not well developed in his case. Now, because of absence of part of this small bowel called duodenum, the food, it cannot go from his stomach down to his gut. And that's why everything that you are giving, it's coming out, and you can also see some bile, because bile is actually something which is green and it stays in the gut. So the food is going into the intestine, but it cannot go far down. So it's coming up, and your child is vomiting every time you are trying to feed him. This is not a very common condition. The exact cause why it occurs is not known. But because your child is just 24 hours and he's not able to take any breast milk at the moment, it is an urgent situation for us. This is a rural hospital, and we don't have the appropriate measure to help your child here. That's why I'm going to call the pediatric emergency retrieval team. I'm going to call the pediatric surgeon in the tertiary hospital so that they are aware of your child, and we are going to send him to the tertiary hospital by air ambulance as soon as possible. In the meantime, please do not feed your child. We are going to insert an IV line and start him with IV fluid. In the hospital, if he continues to vomit, they might also want to insert a flexible tube through his nose into the stomach, and that way the vomiting can be stopped. Now, the only way to fix it is by surgical correction. I'm afraid there is no medication that can solve the issue. I do understand that this came as a shock to you and you are not expecting any of this. But I want you to know that you are in a very safe hand, and we will take care of your baby in the best possible way. The surgical team will discuss in detail about the procedure. If you have any questions about it, please feel free to ask me or also discuss it with your specialist. Most of the time, after surgery, children gets fully better without any complication, and your child will start to feed normally, and then they will also start to grow as a normal child. I'll give you some reading material so that you can go through it, and I would like to review him after his discharge from hospital. If you want me to call your partner or any friends or relatives, please feel free to tell me. I will be happy to do so. Okay, so that will be your explanation in this kind of cases. Very careful that this is a sensitive case for anyone. So just make sure you should show some form of empathy in here. It's must. Okay. Now I was talking about esophageal atresia, tracheoesophageal fistula. We usually do discuss that case in our vomiting cluster role play, but just to give you an idea, esophageal atresia case, 24 hours vomiting, whitish vomiting, or milk will come out. Now, esophageal atresia child, if they have associated tracheoesophageal fistula, because of the connection of the trachea with the esophagus, they can have some other lung-related problem. So they can develop aspiration pneumonia, which can cause difficulty breathing. Child can become cyanosed, so bluish discoloration of the body. You can get frothing or bubbling coming out of the mouth. So that's also possible. Okay. So if a child who is having 24 hours vomiting of white color vomit, that means milk coming out, and child having breathing difficulty, getting cyanosed, frothing, milky bubble coming out, think about esophageal atresia with tracheoesophageal fistula. Okay, we'll discuss this case also in our role play class, and that should do it. Okay, so that's all about this cluster that we have discussed. As you can see that with just a single history physical examination format, we are able to finish this number of cases. Just think that if you have to separately prepare each of these cases, how difficult it can become. So that's where we actually make the preparation very well organized for you. And most of the cases, we are able to put it in a cluster. There are always some random cases which doesn't maintain any cluster, but most of the cases we are able to do it. So it becomes very easy for you to remember. At least if you can remember the history and physical exam, the half of your examination is already done. Management is not difficult, as you can see. Most of the time, management is same. Okay. So that's all about tonight's session, guys. Now I will allow any of you to ask any questions about the course. The trial class is over now. That means free 2-week session is also over. The next class schedule has been already updated in your Facebook course group. And in the course group, sorry, it hasn't been updated yet. So we will update it by tomorrow. You should be able to get it. The orientation class now, it is designed that most likely, let me see that when it will be. So that's fine. We will update you in the course group tonight that when all the classes will happen. So just keep an eye on the schedule and join it. Okay. So that will be the plan now. If any of you has already paid for the course, but you haven't been added to the Facebook course group, please make sure you send a message to my inbox or email us. If this is a fever vomiting cluster and due to time constraint, you only want to ask fever vomiting questions, will they pass you? Now, they might, but I would at least ask bowel habit and water work question. Okay, in a child who is vomiting, even they have fever, I would not forget about bowel habit and water works. If you don't ask intersusception, hernia, that's understandable, but at least bowel and bladder should be asked. In online exam, stem can be very long. It can be, it's not like all the stems are long. Some stems are long, some are normal. The positive findings on the screen, ideally at least for a minute, but if you finish it earlier, you can always ask the invigilator that, thank you, I have finished my reading. Can I please have a look on my questions? Okay, you can always say that. Physical examination classes start after 2 months. So likely to be, say, April, May, June. June will be the physical examination month. You can't make a note in the 2-minute thinking time, not in online, not in face-to-face. Yes, Dr. Delvin, that's the course group 8. Yeah. And that's right, Dr. Pawan, that's the clinical batch 8 is the Facebook course group. Dr. Upul, the email should not contain the payment link. There should be a separate email which send you as just an invoice. If you haven't received that invoice, please just send me an inbox saying that, well, I have tried to send an email, but I haven't got any invoice yet. Or you can just email back in that email that you have sent. Just say that this is my email ID. I haven't got any invoice yet. Okay, then we should be able to send it back to you. For enrollment, Dr. K or anyone else, either you can send a message in my inbox, or you can also send an email. So the email ID is First Aid AMC. So I'm just writing it in the chat box. 4536 at outlook.com. So either you send an email, then we will send you the invoice and your enrollment will start, or you can also send an inbox to my messenger. I should be able to help. Okay. Now, if you have any questions about the course, you can ask me. Now, you must already know about the course in detail. We have discussed it throughout this 2-week session. You also have seen the video of the course. The course has everything that you need to pass the exam. So as we discussed that, we do the theory sessions, just like we are doing now. After the theory session, we do a theory-based role play. You also get every week 1 random role play classes, which is based on the recent cases. And also there is a huge number of role play discussions already done, which is in the portal. You should be able to get all of it. And at the moment, there is 90 role play videos already available, which is a huge collection of almost anything that can appear in the exam. The video recordings are available in the software. If you can't join it as online, you can always finish it just by hearing the recordings. We are actually adding a new thing in your course, is that any of you, if you want to finish your course within shortest possible time, we will allow it to you. Given that you made full payment, we will be able to give you access to the previous batch recordings, which means you will get theory class recordings. You will get also all the recorded role plays. So which means that you can finish it in your own time as well. You don't need to be added to our previous batch. In your batch, you will be able to get it. So we are going to add all of those theory classes recordings. So in case anyone just want to finish it in their own way, they can do it. And again, if you are not in a hurry, try to join the live classes, try to finish everything that we are doing. And if you can at least finish in that way, you are good to go. Okay. And because Dr. Fatima, you might not got the older theory classes still now because this is a new thing that we have added for your course. We just developed it. So I was just talking to the IT team yesterday. They just finished it. So it's still on the way of being added in your course. So it will be available. But if your exam is very near, like let's say in 2 months, then please just send me an inbox again that you haven't got the access yet. Okay, in that case, we will say priority. All right, everyone. Thank you, everyone, for joining these sessions. And I'm sure that you must have learned something from these 2-week sessions. I hope that at least. And hopefully you will have a good time with us in the next 5 months. Okay. In the orientation class, Dr. Mariam, come and join the orientation class. I will discuss how and where you can find everything in the portal. Okay. So all of you who have joined the course, make sure you join the orientation class. We will go through the portal one by one. Okay. Thank you all. Have a good night. Take care. Best of luck. Bye.